We are waiting for the audio and video. Okay, so we just check the audio and video and then we'll start the session. Okay, so it's live. So good evening everyone. Sorry for the delay. There was a technical issue at the back end. Okay, so let's resume. So the topic for today is methods of gaining space in orthodontics. Okay, a part of this lecture was covered in the previous session. So proceeding from that part. So first of all, what is the requirement of space in orthodontics? It is required for the alignment of crowded teeth, retraction of proclined teeth, that is forwardly placed teeth. Once they are present, we need to retract them into the space. Correction of molar relationship from class 2 and 3 to class 1 or the desired. Derotation of anterior teeth, correction of the rotate, leveling of curve of spee, that is towards flattening of the curve of spee. Okay, and lastly for the intrusion of the teeth for correcting deep bite. Okay, so these are the things for which space in orthodontics is required for. So how do we create this space? The various methods are, first of all, by through expansion of the arches, next by proximal stripping, next is by uprighting of tilted teeth. Okay, as we know that tilted or teeth require more space, so by uprighting them we are able to create space. Next, derotation of posterior teeth. Rotated teeth acquire more space in the arch, so by correcting the rotation the space is created. Proclination of anterior teeth. Okay, and lastly through extraction. So out of these methods, arch expansion we dealt in the previous lecture. We are going to discuss in brief about the rest of the other methods. Okay, so beginning with the first method, that is proximal stripping. So what is proximal stripping? Is basically the reduction of the mesiodistal width of the teeth. So it is other names of this is slenderization, disking, proximal slicing, odontoplasty or enameloplasty. And what is the requirement? So what is the indication for proximal stripping? It is done when the space requirement is minimal, that is approximately of 2.5 to 3 mm, and when generally taken through model analysis. How do we judge? So we use Bolton's analysis to judge the requirement for proximal stripping. So when there exists a Bolton tooth material excess, either in the, as we all know, there are two ratios, one is for anterior and then the next one is for posterior teeth. So when the ratio is excess, we go for proximal stripping, and should be generally the rest requirement should be less than 2.5 mm. More than that, if it's more than 2.5 mm, then we go for extraction of teeth. Okay, so how much stripping can be done? So how much amount of enamel can be removed? So according to Sheridan, approximately 1 mm of enamel can be removed from the buccal contact point, that is 0.5 mm on either side, and it should not exceed 0.75 mm, that is 0.35 mm on each proximal surface in lower incisors due to thin proximal walls. So what will happen if we reduce more? There is chances of pulp exposure is there in those teeth. Okay, so that's why the amount of reduction, enamel reduction in lower incisors should be minimal in nature. So what are the different ways which we can do? First is through the least invasive method is through use of metal abrasive strips. They can be double or safe sided. Double sided means both sides can be used for reduction. Safe sided is one side for reduction, and the other is the other side, that is the other side is smooth. So when we move it through to and fro through the contact point, only one side of enamel will get reduced. Next, through perforated diamond disc, safe sided carborundum disc, thin fissure burrs, these all require great manual dexterity while reducing enamel. And lastly is the chemico-mechanical method. It is the least used, that is employs the use of 37% phosphoric acid with mechanical microabrasion using diamond coated metal strips. So these are the various methods to reduce enamel. So these are the images. So these are the commercially available enamel reduction accessory. These are the disc which is attached to a, this is a saw. You just hold it with a and use it like a saw. We have seen the carpenter use it to cut wood. Similar kind of thing is used to reduce the enamel in the inside the patient's mouth. Okay, so this is a like a saw on which this is the abrasive strip is attached. Okay, and we move it through the contact point like this to and fro. These are the carborundum disc, okay, and burrs to reduce. These are the burrs and these are disc, safe sided and both sided to reduce the enamel. Okay, these are the gauges. This is the IPR gauge set. So these are used to measure the amount of enamel which is reduced. So as you can see, if I zoom it, each disc has some amount of measurement. This is 0.1, this is 0.2 mm. So the thickness of this side is the amount of measurement which is written here. So we put it through the contact point, okay, like this, and measure the amount of enamel which is reduced. Okay, so next method is the non-extraction treatment with non-compliance molar distillation. So it is a molar distillation method. Okay, so various appliances which are used for molar distillation are, the first is the pendulum appliance. This was given by James Hilgers. Next, distill jet, Jones chick, first class appliance which was given by Fortini, frog appliance which was given by Voigt. Next is the Wilson's biometric arch. This is the image of Wilson's biometric arch. Next is the K-root given by Dr. Varun Kalra, fixed piston appliance, C-space regainer, and lastly is the use of extraoral headgear. So we are going to discuss in detail about the pendulum appliance. Rest all appliances we are going to see just the images. So what is a pendulum? So it distillizes the molar in a arch shaped manner. Okay, so what is the construction or how does this appliance looks like? It has bands on the first premolars which are soldered using parallel extensions with 0.036 inch stainless steel wire embedded in a Nance acrylic button in the Ruge area along the contour of the anterior palate. So this button, this Nance palatal button, should be at a distance of 5 mm from the anterior teeth. Okay. Next, there is an activated spring made up of 0.032 inch TMA wire which deliver a force of 150 grams, sufficient to distillize the molar partly by bodily and partly by tipping movement. How do we evaluate the amount of distillation? It is evaluated by measuring the distance at the cervical margin of the first molar and the second premolar. This much distance is measured to evaluate the amount of distillation. How to reactivate this? So the reactivation of this spring is, we loosen this spring from the lingual cleats. Okay, using a plier we bend it further and then again reinsert it inside this lingual cleats. Okay, so it's done every 3 weeks. Okay, by opening the helix of the spring with the help of a plier. So on insertion, about 1/3 of the activation is lost. So supposedly the appliance, the spring is here, we open it by 90 degree, so approximately 30 degree of activation is lost. So we just get the activation of 60 degree, that is approximately forces of 150 to 200 grams is delivered on 60 degree activation. Okay, now the springs are again inserted inside this lingual sheets, and what will do, the spring will take the molar along with it distally. Okay, so this is If I zoom it, this is how the activation is done. It is inserted inside the lingual sheath. Once it's out, the springs are like this in the deactivated state. In the activated state, it is inside the lingual sheath. Inside your mouth, how it looks like this. Okay, so once the distalization is done, we need to stabilize the molar at this new position. So what Hilgers advocated, the use of a insta-Nance appliance. Okay, so this insta-Nance is similar to the Nance palatal holding arch, okay, which we saw in during anchorage disc preparation in orthodontics. Just the name is different. He gave it insta-Nance because instantly, once the appliance is removed, we have to give this appliance instantly at the same time. Okay, so it is made up of 0.036 inch preformed lingual crib inserted into the lingual tubes. Okay, next the modification of pendulum appliance. So this is a pendulum X or pendex appliance. So what it does have is it has a expansion screw embedded inside the acrylic button. So what we can do is we can do expansion as well and distalization as well with the same appliance. Okay, the name of this appliance is pendulum X or also known as pendex appliance. Okay, next is the T-Rex appliance. So it's a variation of pendex appliance with a presence of additional wire which extend out from the acrylic plate and solder to the molar band. So this is the additional wires which are present, which are soldered to the molar band. So what is the advantage of this is, in the pendex appliance, the expansion and the distalization was occurring simultaneously. Now what we can do is, once this thing is soldered, there won't be any distalization. So first, sequential or the movements are divided into two parts. First, there is expansion is there. Once the expansion is complete, this distal extended solder arms are cut and now the distalization can proceed. Okay, so this is the variation of the pendex appliance. So these wires prevent the pre-activated spring from distalizing the molars until the arch has been expanded to the desired extent. Okay, so this is the variation. This is a hybrid T-Rex appliance. So whenever this hybrid word is attached to any appliance, hybrid means there will be presence of palatal implants or TADs. Okay, any appliance can have a hybrid version of hybrid pendulum appliance, hybrid T-Rex appliance, any. So it will have a presence of what will be the hybrid variation? It will have the presence of temporary anchorage or palatal screws so as to avoid anchorage loss. Okay, so this is the hybrid T-Rex appliance with the presence of anterior palatal screws in it. Okay, next is the lip bumper appliance. So what does it do? It distalizes. It has a distalizing appliance as well, and you can have as a space regainer and indirectly as a functional appliance as well by shielding the hyperactive mentalis muscle. Okay, it extends slightly beyond the mandibular incisor and connects distally into the mandibular molar. So what are the indications? It helps in lip sucking. Okay, avoid cessating lip sucking happen, hyperactive mentalis activity, anchorage preparation, molar distalization, and acts as a slip bump space regainer as well. So when this lip bumper or plumper or a modified vestibular screen is given in the upper arch, it's known as Den Holtz appliance. Okay, so this is the other name of lip bumper appliance when it's given in the maxillary arch. So how does it act? As we can see, this acrylic plate is constructed at a slightly distance from the lower anterior teeth. So what will do? It will lift the muscles away from this appliance. So what will do? The muscle forces will act on this shield and through this wire it will go on this molar, which will get distalized. Okay, so this is the way through which lip bumper acts. Okay, next this is the distal jet appliance. Okay, this is the image of first class appliance. So the what is the difference between the two? In distal jet there is only palatal method of distillation, whereas in first class appliance both buccal as well as palatal springs are there for distillation. So please just see their images very carefully in order to differentiate during your exam. Next, this is the Jones-Jake appliance. So this is the only appliance which acts from the buccal side for distillation. This is the how the appliance looks when placed in the mouth. Next, this is the frog appliance. So this appliance image came in your NEET, previous NEET 2024 or I9 May 2024 exam. So this is the trademarked appliance by the company Foresta Dent. Okay, so this looks like the legs of the frog, the arm. That's why they name it as frog appliance. Okay, so it has two palatal screws embedded in the anterior region. Okay, these are two screws, and once we turn this key, so what will do, this key will open up, and along with it, it will take the molars in the distal direction. Okay, this is how this appliance acts. So these were the images or the discussion about distalization. Next comes the derotation of posterior teeth. So as I have told you, rotated teeth acquire more spaces. So how do we correct? We correct them by applying couple forces from buccal and lingual direction so as to correct their rotation. Okay. Next is through proclination of anterior teeth. So in cases where teeth are retroclined or the proclination will not affect the soft tissue of the patient adversely, we procline the teeth in order to gain the space. It leads to the increase in arch length and thus providing space for the desired thing. Next is by uprighting of tilted posterior teeth. Sometimes the teeth are mesially or distally tilted, which lead to acquiring more space in the arch. So what we do is uprighting those teeth in order so as to gain more space. So they form part of the interceptive orthodontics known as space regainers. So what are space regainers? So what are the space regainers used for? So basically, what are the causes of, first of all, mesial tipping or drifting of the molars? They can be due to premature extraction of primary molars or due to extensive carious lesion in the anterior teeth to the molars, and either due to ectopic eruption of the molars. So what is the timing of distalization? When should we give the space regainer? So before the age of 9 years. Why? Because before 9 years the roots of the permanent first molar are not complete. So what will be the advantage? We will be able to achieve more bodily movement than tipping of the teeth in the distal direction so as to gain more space. Okay, that's why it is said the timing should be generally space regainer should be given at an age less than 9 years, or a time you can verify it through radiographs as well, when the roots of the permanent first molars have not completely developed, so as to achieve more bodily movement rather than tipping of the teeth. These indications, these causes are very important because these causes becomes the indication for space regainers. In your exam they can give you in the form of image based question in which there will be a mesially tipped teeth with the anterior carious teeth. So in those cases you need to go for space regainers. That's why I have mentioned these points in a theoretical format. Yes. Next, what are the methods of space regaining? So there are two types of appliances. We can be broadly divided into two kinds, that is fixed and removable. Fixed are the open coiled space regainer, which is known as Hurst space regainer, jack screw space regainer, and a Gerber type phase space regainer. Removable are the upper and lower Hollies appliance with helical spring, Hollies with split acrylic dumbbell spring, Hollies with a slingshot elastic, Hollies with a palatal spring, and Hollies with a expansion screw. So these are the images of the fixed space regainer. First is the Hurst type space regainer. So what does have? These have two arms, which are buccal and lingual arms, which are parallel to one another in all planes of space, and their aim, it should be, and this bridge connecting this buccal and lingual arms should be at the junction of the crown and gingiva. Okay, next, this is the construction. Next, there is a presence of compressed open coil spring. This coil spring is compressed. So what will happen once this compression is relieved? This will push these teeth in the forward direction. This compression, when it's expand, this will push, and at the same time this reciprocal action on this posterior molar will be, it will also get distalized. Okay, so this is a Hurst type space regainer. Next, as it is the jack screw space regainer. So what will have? It will have acrylic plate, and this will be, there is the jack screw with the acrylic plate attached to it. So once we open this screw, what will happen? This molar will get distalized. Next is the Gerber space regainer. Construction is somewhat similar to the Hurst type. It has a U-shaped assembly used into which a U-shaped wire can be fitted. Okay, so this is how. Basically, it has a telescopic mechanism. What does telescope has? It has a tube within a tube. So similar, there is a tube inside which a wire is present. So this is compressed, and similar kind of mechanism which exists in the Hurst. This compression is relieved as the space appliances distalize. Next are the removable space regainers. Okay, so first is the Hollies with the helical spring. Okay, so this is the present. I'll just zoom it. So this is the location of the helical spring. So we take out the appliance. When we open this spring on subsequent appointment, so that the molar is distalized. Okay, next is the Hollies with a dumbbell type of spring. So this is a dumbbell spring. So the helices or the arms of the spring are opened so that the molar gets distalized. So this next is the Hollies with the appliance with the slingshot elastic. So this appliance in which the elastic is attached from this spring. So there is an arm for the spring from which this elastic is attached to it. So what will happen? As the elastic gets compressed or regains its space, this will take the molar back or distalize it along with it. Next, Hollies with a palatal spring. So there are two palatal springs present here. We just have to open the helix like this so as to gain space in this region. Next is this sliding yoke type space regainer. Again, the presence of a compressed open coil spring. As the coil spring relaxes or open up, it will gain the space. Okay. Next is this appliance, that is the franzulum appliance, a very important appliance in the image. This is the only appliance which is used for distalizing the mandibular molars. Okay, so this is the franzulum appliance. Next is this knee spring used to tip molars distally. So this is the spring in which is placed between the undercuts of the two molar. We just have to activate or compress this spring like this so that the molar moves distally. Okay, so these are the various space regainers. Of the images of these regainers are very important for your exam. Next is the Next are the extractions. First we'll start with the camouflage. Sorry, there was a certain loss of connection from the backend. Just checking if it's online. Yeah, it's back. Sorry for the interruption. So as I was saying, next we move towards the extractions. Okay, so okay, thank you. So moving towards the extraction pattern, so we'll start with the first of all the camouflage extraction pattern. So what is camouflage? Camouflage means to hide. Okay, so as to hide certain things. So what do we need to hide? We need to hide the skeletal discrepancy. Okay, the skeletal discrepancy can be in the form of skeletal class 2 or class 3 malocclusion. So we need to hide the skeletal discrepancy by just by dental corrections. So how do we do that? For that we need to perform certain extractions. Okay, so who are the patients who are the good candidates for camouflage treatment? First, who are too old for successful growth modification, that is through functional correction we cannot achieve their skeletal modification. Next are those who are mild to moderate skeletal class 2 or mild skeletal class 3. Okay, so how do we judge them of mild nature? Through their soft tissue profile. Okay, next, there should be reasonably good alignment of the root, means there shouldn't be too much crowding. Lastly, there should be good vertical facial proportion, neither there should be extreme skeletal deep bite nor extreme skeletal open bite. Basically, the cephalometric parameters should be in the mild to moderate range, they shouldn't be too severe in nature. So what are the cases that should be avoided? Severe class 2 to moderate to severe class 3. Next, vertical skeletal discrepancies, patients with severe crowding or protrusion of incisors. Lastly, adolescents with good growth potential. So in those cases, we should go for growth modification first, and in camouflage treatment or orthognathic surgery should be reserved for those patients in which the adolescent or the growth modification period has already passed. Okay, so these indications, as I've told you, are very important for your exam, because in your exam what you get is a big paragraph in which they'll just give you certain points, certain ages. They'll ask you what are in the options, they'll provide you with treatment options, so you should know. So what case history for soft tissue profile? No, I did not mention about case history. I said how will you judge whether it's a mild class 2 or class 3. So one way is through cephalometric parameters. So this is the radiographic method, and clinically through soft tissue profile, whether what is there in skeletal class 2 or class 3. If it too much skeletal class 2, it will have too much convexity. How you cannot camouflage it through extraction. Okay, the profile should be pleasing, already pleasing, but on radio it is skeletal class 2, but the profile is mild convex or even straight as well. Then those cases you can treat with camouflage extraction. That's what I said. Likewise, in skeletal class 3, what we see is a concave profile, but certain cases with straight profile, okay, or mild concavity are there, so you can treat those cases with camouflage as well. Okay, that's what I said. Okay, there are certain cases which are skeletal class 3 in nature, true skeletal class 3 with concavity. Those cases we also treat with them genioplastically as well. We just do chin reduction and the case is done, because the patient just has a chief complaint of protruding chin. Okay, so those cases we do not need to go for a full-fledged orthognathic surgery with PSSO and all. We just camouflage them with genioplasty. Genioplasty is also somewhat part of camouflage options as well. Dentally we correct them through extraction, and this protruded chin we just correct through Genoplasties can be done in outpatient as well. No need for long admission and proper orthognathic surgery. Okay. So what are the extraction pattern in camouflage cases? So first, in class 2 extraction pattern. So first scenario will be all for extraction. Okay. In what case will you go for all for extraction? When we have severe arch length tooth material discrepancy in both upper lower arches. Okay, means there is severe crowding in both arches, then we need to go for all four extraction. Similarly, upper 4 lower 5 extraction. So upper 4, when there is crowding in upper anterior teeth, okay, and lower 5, what we do for lower 5 extraction is done for mesialization of the lower molar, so as to achieve class 1 molar relation. Okay, so there is mild crowding and the rest of the space is used for mesializing the lower molars. Third scenario, only upper 4 for extraction. So there is discrepancy, and this discrepancy can also be in the form of proclination as well. Okay, so there is discrepancy only in upper arch. So what will we do in this case? We'll just extract upper 4. So what will we have is a class 2 molar relation, the end scenario, and class 1 canine. Okay, next we can go for upper 4 lower single incisor or upper 4 lower 2 incisor extraction. So upper 4 again for discrepancy in the upper arch, and lower single incisor to lower 2 incisor when there is mild to moderate discrepancy. Mild discrepancy, like what will be the scenario when there is locked out incisor are present. So in that case we can go for lower single to lower 2 incisor extraction as well. Okay, why? Because if we extract 2 premolars, average dimension of one single premolar is at 8 mm, so we get 16 mm of space, as compared to 5 mm का एक incisor हुआ तो we get just 5 mm to 2 incisor to just 5 to 10 mm space. Okay, so in those cases we can go for based on the model analysis. Okay, based on that we go. So similarly there is a class 3 extraction pattern as well. So class 3, what will we have? I'll just write it with a different ink. So class 3, so first scenario is same, all for extraction in class 3. So when there's severe arch length tooth material discrepancy in both arches. Next, in class 3, next scenario will be completely opposite. So in upper 5 lower 4. So severe arch length tooth material discrepancy in the lower arch, and upper 5 so as to mesialize the upper molar so as to achieve class 1 molar relation. And third scenario would be lower 4 extraction, just to correct the lower tooth material discrepancy or lower incisor proclination. There is no fourth scenario in class 3, that is one upper single incisor. Why? Because the upper incisors comes in smile and direct visibility, so we cannot extract one incisor because the smile will get deranged. Okay, so there is only 3 scenarios in class 3. These extraction pattern, these camouflage extraction patterns are exactly opposite when we go for orthognathic surgery. So there comes the decompensation extraction pattern. So here what we are doing is camouflage, there comes the decompensation, so it will be exactly opposite. Class 2 extraction pattern will be exactly opposite. Reasons we have discussed already in the lectures. Okay, so moving ahead comes the Wilkinson's extraction. So it was an age-old phenomena. Some of you might have also undergone or seen your classmates have this missing permanent first molars. So what it was thought in the early time was that first molars are highly susceptible to caries. Why? Because they're the first permanent teeth to erupt in the mouth, and next they lead to impaction of the third molars. So the age-old thinking was so as to extract these teeth at the age of 8.5 to 8.5 to 9 years, so as to provide space for the eruption of third molars. Okay, so what was the drawbacks? Early, as this time progressed, studies were done. It was found that if we extract first permanent molar, there was hardly any space for correction or crowding. Permanent first molar is a posterior tooth. Mostly what we get is a crowding in the anterior region. If we extract a teeth in so much posteriorly, what will it do? We won't get any space in the anterior region for correction of crowding. Next, the adjacent teeth generally tip into the extraction space. There is no such bodily movement of the second and the third molar into the extraction. They just tip easily. Okay, so that's why there is no point of extracting first molars and in the hope that the second and third molars will move bodily and acquire the space. And lastly, the principal anchor unit for orthodontic appliances loss. First molars are generally used for anchorage. Okay, either nans palatal, transpalatal arch, or any kind of anchorage preparation. We require the presence of first molar. Why? Because of the thick or the three roots. The upper, if you remember Friedman's anchorage value, the periodontal surface area of these teeth are very much. Okay, that's why this Wilkinson's extraction is no longer advocated. Nevertheless, it is important to remember this name for your MCQ exam point of view. Okay, next comes, there are two terms, compensatory extraction and balancing extraction. So what are compensatory and balancing extraction? Balance matlab balance out karna, means extraction in the same arch. Supposedly we take out one premolar, first molar from upper right side. So as to balance it, a similar molar is extracted from the opposite side of the same arch, and compensatory is in the opposite arch from maxilla and the mandible, so as to compensate it, so as to just settle the occlusion. So these are the two terms which you should know. What is compensatory and balancing extraction in orthodontics? Next comes the serial extraction. So it is a type of interceptive orthodontics. So what is interceptive means? It to intercept or stop the development of full malocclusion. Okay, so what is the benefit? It reduces the time, the cost of treatment, and discomfort to the patient, and the time lost by the patient and the parents. So what is this time? So what we do is, generally we intercept the development of occurrence of full malocclusion, which will happen once the permanent teeth erupt, so as to intercept it to develop, so that to avoid its development into a full-blown malocclusion. So what will happen? Once the permanent teeth erupt, the patient will require a less intensive orthodontic, or at some times no orthodontic treatment as well. So the cost and the time will get reduced, and the discomfort caused to the patient by a full-fledged orthodontic treatment will also get reduced. Okay, so it is generally initiated at the mixed dentition period, so as to avoid development of fully matured malocclusion in the permanent dentition. Okay, so certain names, historical names. So the term was coined by Jelgren of Sweden. It was popularized by Hayes Nance, who is considered as the father of serial extraction. And lastly, the Rudolf Hortz of Switzerland gave it a term, guidance of eruption. So what are the indications of serial extraction? There should be class 1 malocclusion with a discrepancy of 5 mm per quadrant, that is 10 mm in total. And there should be a normal eruption sequence and skeletal growth pattern within normal limits. Means it should be a class 1 skeletal growth pattern with the average towards mild horizontal in growth nature. Localized gingival recession in lower anterior teeth. Ectopic eruption of teeth. Upper unilateral to bilateral premature loss of deciduous canines with midline shift can be there. So these are the indication. Most important is this first one for exam, that is the amount of discrepancy with the growth pattern and the growth nature. So what are the contraindication? Mild to moderate discrepancy, if the discrepancy is too mild, which can be solved without the need for any extraction. There is skeletal class 2 or class 3 malocclusion is there. This space dentition has space, so there is no need for extraction. There is congenital absence, either oligodontia or endodontia quality of teeth or less, and we cannot go for more extraction of teeth. Presence of open or deep bite, as I've already told you, the growth parameter should be within the average to normal range. There shouldn't be any extensive caries involving the first molars, which in turn cannot be saved. So there are few methods advocated by different scientists. First, the Tweed method, who said extraction of D first, followed by the first permanent premolar, followed by C. Dewell's method, he usually followed in the low arch. The extraction pattern was CD4. Nance method was similar to Tweed, D4C. So the important is modified Dewell's method, in which he said what he used to do was the enucleation of premolar along with the extraction of D. Okay, but Moyers later on said that if we prematurely extract or enucleate the permanent first premolar, the alveolar bone or that area won't then develop properly. As we know, the eruption of teeth leads to the proper development of the alveolar bone. So it is said that let at least 3/4 root of the permanent first premolar develop, then only go for its extraction. Okay, next, what was the reason behind extraction of deciduous canine? So as to allow proper eruption of lateral, so and the improve position of the central incisors, also prevent